I'm Natalie Garland, and I'm here with Derek Berkey this morning. How are you, Derek?
Doing great.
Yeah.
Doing great.
Good. I'm excited for this podcast today and for our guest, Dr. Urson Religioso, who's a doctor of physical therapy, manual therapy fellow, and a mentor to physical therapists all over the world, and specializes in a lot of like back pain. And I'm really excited because my back has really been hurting.
Has it?
Yeah, primarily just from like carrying the weight of this podcast.
Wow. Okay.
Sorry, I had to go there. But I'm really excited for our listeners to hear this conversation with Dr. E. He has so much knowledge and passion surrounding this subject, and to hear Dr. E talk about what's actually happening in the body when people are experiencing pain, because a lot of people, was like 80% of people experience back pain, especially lower back pain.
Yeah. I mean, I think that back pain is something that a lot of people struggle with, and just like pain in general, you know, like I think that the chronic stress that people feel and that experience on a day-to-day basis, it all feeds into kind of like this, it feeds into pain. And so I think that we're going to get some really cool and really good tools to be able to utilize on a day-to-day basis. So
yeah, I'm excited for people to hear Dr. E talk about what's happening in the body when they're experiencing pain, and hopefully come out of it feeling like they're going to be better able to attack whatever is going on in their body and find some relief and some healing. Dr. E, welcome to Invigor Medical Podcast.
Yeah, thanks for having me.
Yeah, we're really excited to have you on today. We typically do kind of a free-flowing podcast, but with questions to go back to. So I'm excited that today you were like, no, let's just go for it and get into the questions and have a conversation. Yeah. So
let's prep. I don't even know what that means.
You did make a joke earlier that you were just a walking soundbite, so I'm excited to see that live in action as we're recording today.
All right. Yeah. Hopefully. Wow. I hope I didn't hype myself up too much.
Right. Set the bar a little too high for yourself, maybe. No, I think you're going to do fantastic. Yeah. Why don't we start with a little bit about you and your background and how you got here sitting in this chair and, you know, your passion for physical therapy.
Yeah, well, actually, I'm not even sitting on a chair.
Oh, you're
of course.
For those
on a chair,
physical therapist fashion, sitting on a
why would I be static?
Stability ball. I love it.
Why would I be static? I just got to keep on moving, right?
Maybe we need to get those for the studio in here. Just be bouncing.
You just see me constantly bouncing in the videos.
Yeah, I know. I have to control myself to prevent myself from bouncing.
That's funny.
It wouldn't be good for the camera.
You're on a Zoom call.
Motion sick. Yeah. So, yeah, I've been a physical therapist for 26 years. I originally graduated with a BS and MS from DeVille College in Buffalo, New York, and that's where my practice is. And right around that time, I wanted to become I was really interested in manual therapy and particularly spinal manipulation. I thought the end all be all that would make me the best physical therapist in the world was if I was able to learn spinal manipulation. My parents are medical doctors, and at the time they were really against like traditional chiropractic. That goes back to way back in the 60s when like medical doctors tried to smear chiropractors, and there's like this committee around quackery, and they were, that's why chiropractors started calling manipulation adjustment, because manipulation sounded like literally trying to manipulate your mind as opposed. So adjustment sounded, much more gentle. But they said, hey, you know what? We're basically going to disown you professionally and potentially from the family if you become a chiropractor. So I learned that there was this route of manual therapy fellowship where I could study in this new doctor of physical therapy program in St. Augustine. It was probably one of the first doctor of physical therapy programs in the United States in 1997, 98. So I literally applied to this program 2 days after I graduated, and I got in and I just started going right back to school. Like I had one weekend off and I started going right back to school. I ended up doing a manual therapy fellowship and residency with my mentor, Dr. Ron Schenk, who was also my orthopedics professor. He was the reason why I got so interested in manual therapy. And I learned that there's a whole lot of things other than just spinal manipulation. There's soft tissue work and nerve flossing and a whole other host of things. And I wasn't satisfied there. I learned that there was like all these gurus, like every profession, I don't know, maybe physical therapy more than most. We have all these gurus, of like Maitland and McKenzie and David Butler and all these guys who kind of like have just made a name for themselves. They have a whole series of seminars and you can get certified in their approach. So that was my next goal. I'm going to get certified and get as many credentials after my name as possible. I don't know if you've seen my bio. I have like lots and lots of letters after my name. And at first that was my goal, to be more credentialed than anyone else. And also I'm going to learn from all these gurus because there could be only one, and I know these guys are all going to die off one day. And I thought I'm going to replace them. Like, just so arrogantly, I just thought I'm going to be like the next big thing. I want to teach all these seminars.
Lofty goals. I love it.
Right? Yeah. I mean, I even told some instructors so arrogantly that, hey, they're like, why are you taking this course? I'm like, I only want the credentials. I'm not even going to use your approach. You know, like,
oh, wow.
I know. I was the worst, right? And then I started blogging in about 2010, 2011. I had one of the first like main PT blogs. I was one of the first kind of PT influencers before PT became influencer was a word.
Yeah.
I had this really popular blog at the time, back when people read, on the internet instead of listened.
Yeah.
And watched like a minute and a half vertical video.
Yeah.
Seriously.
So yeah, that really blew up. It was called themanualtherapist.com. That's still in existence today, but mostly for like a kind of evergreen content. So that kind of put me on the map. And I started like teaching, trying to promote like this particular product that I sold, like a handheld tool. Let me go get that.
Is this a Graston?
It was this thing
for
like
Graston
mobility. Tool. Yeah, it's not really Graston though. The whole point was that Graston tools are $3,000, and I was able to sell this for like $120.
That's amazing.
So I literally sold.
Is it like
I sold like thousands
device?
of them.
One of those torture devices that you just like dig into your muscles.
Basically.
Yes, that is part of my journey, because when I initially developed it, I was a rock climber, and I said, like, I need to save my hands for rock climbing. So I was beating up and bruising patients so much that I thought I need to use a tool to make it better. And I thought, these Graston tools are too impractical. Even though I was a successful physical therapist, I thought something can be done to like bring this to the masses, right? So I started selling that on Amazon, and then eventually got an e-commerce store, Edge Mobility System. I started branding like a bunch of different products, white labeling them, but making them much more accessible to not only the public, but also to clinicians who don't necessarily have like thousands of dollars extra to spend on their practice.
Can I just take a moment to highlight how incredible that is? Like, I don't know. I'm coming from working in a physical therapist clinic as an aide, and like seeing all the physical therapists like setting the Graston tools up on like this podium. It's like a shrine of Graston, and like if you took one of the tools and dropped it, they would get so mad. And so I was always
like the whole clinic just is quiet because it's like, oh man, he just scratched, like, did he scratch the $500 tool or the $700 tool?
Yeah, and I never understood it, because I'm just like, these are just like just pieces of metal with this bevel. Like, what? Like, how could this cost so much?
There's a big markup on those things.
Yeah, so I think it's incredible.
They're also like wrapped up in the cloth, right? And I just said this on a podcast 2 days ago. Like, you unwrap the cloth, you expect it like light to come out. The box from Pulp Fiction. The box from Pulp Fiction that like everyone opens and like it's like glowing and everyone's looking at it. But it's just like a mystery, right? Like these things are so special. And not to say that my tool isn't special. I just say, if you drop it, not the biggest deal in the world. If it gets a couple scuffs, not the biggest deal in the world.
Yeah, it's a piece of steel.
Right? So yes, it's steel.
Yeah.
It's nothing more special about it. I mean, I do say it's covered with pixie dust too, my particular version.
Oh, yes.
Of course, absolutely.
Right, yeah. So I tried to start promoting that, and I realized that there's no reason to go back to hammer.com, right? Like, you buy one of these things, you buy a hammer, you never go back to hammer.com, so you essentially know how to use it. So I thought, well, I'm going to start showing videos of me using it. And then people got interested, not only that, but my particular background of having like kind of amalgamated all these different approaches from all these gurus I listen to. So that's where my brand, Modern Manual Therapy, and what I call the eclectic approach, because it kind of fits in with my whole E brand, like Dr. E, my first name, Urson, and that tool is called the Edge tool. So everything like went around the E as a logo. And I actually ended up getting teaching gigs all over the world because people were so interested in my YouTube videos. And it ended up being a lot less about the tool and more about how I eventually kind of combined like a McKenzie approach, which standard modern manual therapy, and what's called pain science education, which we'll get into later about the back pain, to kind of like empower the patient. Because I went from, I have these magic hands that are going to fix you, and my x-ray eyes can tell exactly where the points that need to be like elbowed out, or like I need to just like work on these things until you feel better. I need to bruise you because I'm breaking up scar tissue, to now I use this tool with like the force of a cat or dog licking you, and I'm so gentle. And I think that every single technique can be and should be pain free. Like no one should ever be sore from physical therapy unless it's like delayed onset muscle soreness
Right.
from exercise. So that's my transition of, initially wanting to sell a tool, and my first videos in like the first year that are still available on YouTube, where I was showing people like before and after, you got to bruise people to actually get this done, to now use the force of a cat or dog licking you, because it's impossible to break up scar tissue.
Impossible to break up scar tissue.
It's impossible.
And so, yeah, all these people are going through all of this pain and these bruising and getting literally beat up, and there's no reason for it.
Yeah. So let me ask you this question. How much force do you think it takes to stretch out fascia, which is like, everyone else is working on fascia. Fascia is kind of like when you peel back the skin of a chicken, it's like the white stuff in between the skin.
Right,
and
that
the
like
meat.
little layer
kind of connective tissue.
Yeah, it's like little layer of connective tissue. It's like kind of like, it's really thin.
Mm-hmm.
So to form fascia 1%, it takes thousands of pounds of force, thousands of pounds. And it's not to say that I shouldn't say it's impossible. I would say it is very impractical to think that you're doing it with your hands.
Okay.
They've also done other studies where they remove, like say for the sacroiliac joint. Everyone else says like, I used to say this too. Oh, your hips are rotated; they're out of place, right? Like, oh, you bent forward, you heard a click, maybe you didn't hear a click, but let me palpate you with my magic hands, and oh, your hips are rotated and they're out of place. But they've done studies where they remove all the skin, the glutes, all the tissues, everything that like comprises the whole pelvis on like a fresh cadaver, and the only thing that's left are the ligaments that are around like the sacrum, which is the triangular bone of one of the bones that they say go out of place, and the two iliac crest bones. And someone in one of my classes actually said this, and they said this was like an experiment for PTs learning how to be manual therapists in a particular program in Australia. And they said, okay, now that we removed all the supporting structures that the average like living person has, the only thing that's left is these ligaments and these three bones. Now try to take them apart. And they said it took them over an hour with a hammer and chisel.
Wow.
That was the only way they were able to take it apart. And both these girls did the CrossFit. They were like huge, really jacked, really fit. They said they were like sweating by the time they were done.
Holy cow.
And that's after you remove the glutes and the tissues and everything else that supports it. Another really good example is I've heard a surgeon on a podcast just laughing at, PTs or chiropractors or massage therapists making the claim that the pelvis is out of place, because he said that, so he's like an ER doctor. He says that in a head-on collision, typically, again, people maybe slamming on a brake, something like that. So if say you're slamming on the brakes, then you get hit, again, thousands of pounds of force. Since the femur, right, like the largest bone in the body, the femur actually fractures before the pelvis goes out of place. Like that's how strong
Holy cow.
our bodies are. So again, if it takes thousands of pounds of force to break up tissues, plus it takes even more for like the pelvis to rotate out of place, it's not to say that manual therapy doesn't work, because manual therapy definitely works to improve mobility and to decrease pain, but it does not work for mechanical reasons. There's not like a simple fix of like, oh, I'm just going to do this and now you're going to be put back into place. Because if you can get put back into place that easily, either like your therapist is Superman or the Incredible Hulk or, like superhumanly strong,
yeah,
or they're not doing that. And the other question I also ask in my courses too is if we could break up tissues, like what would be the difference between me using a tool or my hands or an elbow or something like that, or what's called the ground reaction force of a fall? Like if you fall and you sprain your ankle, the difference with that is it probably is like maybe a couple 100 pounds of force, but it's also really quick. So when it's quick, you need less force to rupture something. When something ruptures, like when a muscle ruptures or a tendon ruptures or a ligament ruptures or tears, it's actually acute trauma. And so then there's bleeding and there's inflammation, and then the body makes that area sensitive, and it hurts to touch, it hurts to move. So what would be the difference between like the ground reaction force of an acute trauma and our hands? Like if I was breaking up scar tissue, it would actually be an acute trauma, and you wouldn't feel better, you would feel worse, because you would be bleeding internally if I actually broke something up.
At that point, you just be creating.
Well, you can't even really create new scar tissue, because new scar tissue. Well, I mean, yes, if you actually created an acute inflammatory process, it would eventually scar tissue would be laid down.
But scar tissue increased, yeah.
Right. But scar tissue isn't necessarily a bad thing. I mean, we're not lizards is the thing, right? Because lizards regenerate perfectly. We're not lizards or Wolverine who has like a healing factor who can like
Unfortunately.
exactly heal back whatever, or the Incredible Hulk and like you cut off his arm, he can actually regrow an arm. We're not like that. We actually, everywhere we've ever been injured, we just lay down scar tissue, and scar tissue is not a bad thing. It's just a result of the healing process. Can potentially it be weaker or tighter? Sure. But I mean, most people just continue to move, and scar tissue, along with a lot of other things, and I alluded to this earlier, which is what we call now modern pain science, which is not even really modern anymore. It's like over 20 years old. Modern pain science has identified so many things about, or essentially myths about what causes pain. It's not like disc herniations or degeneration or osteoarthritis or inflammation or scar tissue or something being in and out of place. All that has pretty much been disproven to cause pain. Can they potentially sensitize the system to make it more sensitive so that certain movements hurt? Yeah, but I mean, it turns out that a lot of these findings, like disc issues or arthritis, moderate to severe arthritis, all of those have been found in completely asymptomatic people when they started like over 20 years ago scanning people and looking at MRIs and CAT scans and X-rays of completely asymptomatic people. And it turns out that they have a lot of these same issues that people who are in pain have. So it's really hard to say that disc issues cause pain or arthritis causes pain when asymptomatic people also have these things on scans.
Yeah. Sorry.
No, you go.
I was just going to say, it sounds like we've kind of gotten ourselves to a good point to talk about back pain. Because we're talking about pain in general, but I don't know.
Yeah, well, I'm just curious because this whole line of talking started with, you talking about using this tool and it's like as gentle as a dog or a cat licking you. And then you're like, also, you literally all this force can't move these things. And so I'm like, well, then how does this other tool work then? That's what's going through my head.
Well, yeah, I mean, you know what? I probably still the majority that I sell, they all work the same way. So it turns out that whether you're getting scrapes or if you get like acupuncture or dry needle or you get like an adjustment or what we call manipulation physical therapy, we don't call it adjustment, or if you get an injection or anything that works rapidly. So pain is purely a result of your central nervous system or your brain detecting threat. And this is a subconscious detection. It's not necessarily a conscious detection.
Okay.
So this is like the basis of pain science. Pain science, again, from like 2002 when these certain two physical therapists in Australia started pioneering this movement, again, looking at like the scans of completely normal people, they realized that pain is purely a result of when your nervous system detects threat. If there's and the example is this guy, this physio, Lorimer Moseley, he's one of the most charismatic physical therapists. You could ever get him on podcast, it would be great. But
okay.
What was the name again?
Yeah, we'll make a note of that.
Lorimer Moseley. He even has like this video where he's telling this story is on a TED Talk actually.
Oh, cool.
And so he's like hiking in the outback and he thinks he stubs his toe. So his toe hurts, but he finishes the hike. And then I guess when he takes his boot off, I guess his foot may be like really swollen. He's like, well, that's really weird. Like, why does my foot look like this? He goes to the ER, or I don't know what they call the ER, the ED in Australia these days. And they said, well, hey, it's really a good thing that you came here because you got bit by like the most venomous rattlesnake in all of the outback, and you'd be dead. You'd be dead if you wouldn't have come here. The next time he's like, oh my gosh, like I can't believe I narrowly survived, right? The next time he's hiking, and so he barely had any pain. He just like, oh, I stubbed my toe. I can finish the hike, right? But now, the next time he's hiking, he stubs his toe. He experiences severe pain, right? Because he's reliving the whole experience of,
right.
Oh my gosh, did I just get bit? Am I going to die? So it's all about the perception of threat, right? Another good example of this is I'm probably older than you guys, but I don't know if you know who Carrie Strug is. You know Carrie Strug, the Olympic gymnast?
Yeah,
I don't.
I totally know who that. Like it's from way back. It's like early 90s, right? She was like big one.
Early 90s, yes. Yeah, she thought she sprained her ankle. She had to she did one vault. She landed wrong. She thought she sprained her ankle. And she basically has to have like this perfect vault to beat whatever, to get to gold. She ends up like landing perfectly. And then she like hobbles off and she's carried off by her coach. She only thought she sprained her ankle, but it was really fractured.
Holy cow.
That's right.
So
I do remember that story.
if she had known it was fractured, if she had gotten the results of the X-ray, chances are she would have been in a lot more pain and she wouldn't be able to do that. But I mean, again, it's all about the perception of threat. And, again, there are a couple other researchers who are like, if you had an ankle sprain and you're hobbling across the street, but a bus was coming for you, like the bigger threat kind of takes precedence.
Right.
You don't necessarily feel pain, right? So it's not to say that, again, a fracture doesn't cause pain or inflammation doesn't cause pain, but it's purely about how much threat does the nervous system detect? Because the nervous system is purely trying to protect you. So again, when people were like, oh, my MRI says that I have severe degeneration and I have like this L4-5 disc herniation, it's pinching on a nerve, like all these things are what I call thought viruses, right? They're like, like degeneration, it's severe. And another thought virus is your surgeon might say like, oh, well, you needed surgery yesterday, like these terrible messages like running is bad for your knees or deadlifts are bad for your back. And it turns out, again, all these things have been totally disproven. Running is good for your knees. Deadlifts are actually good for your back. And, I'll say things like, well, there's actually a good amount of research that shows that if you take 1,000 pain-free people off the street and you MRI all of them, anywhere between 50 and 70% of them may actually have disc herniations and they don't have pain.
Wow.
And, it's one of my questions to any low back pain patient, a neck pain patient, or a patient with any kind of pain who's received the bad news of a thought virus on their scan. Like, look, even if your pain might be 10 out of 10 at worst, but is it come and go? They might think it's constant, but usually, I tell my definition of constant is from the moment you wake up to the moment you go to bed. Constant to me means you always feel something. Like as soon as you're conscious, you feel it. You can't get busy and ignore it. It's the same in every single position. You're like, oh no, it's really just kind of worse in the morning and better as the day goes on. And again, it's worse when I get home. I'm like, well, do you think if they X-ray or MRI in the morning and then like when it feels worse and you get the same X-ray again in the afternoon, you get the same X-ray in the evening, like you get bad news on an X-ray, it's bad no matter what. But if there are times when it's come and go, that means that it can't possibly be only related to however your scan looks like.
But there's something else. That story kind of reminded me of kind of a story on the flip side, where it was like a construction worker stepped on a nail. And the nail went completely through the shoe. And he's like, oh, he's in the most pain he's ever been in his life. He goes to the ER, they take the boot off, and the nail went between his toes. So he was never punctured. So it was all perception.
Yes, that is actually told in like some pain science classes. And there's another one actually. I thought you were going to say this one because that's a classic one. There's another one where a construction worker or some guy, he dropped his nail gun. It goes off and he's just like it goes off like upward. He's like, whoa, I mean like,
I'm dead.
I'm just so lucky that nothing happened. Right. So months go by, this guy eventually develops headaches. He eventually gets like some sort of head scan or something. Gosh. And then it turns out that this nail went up his nose and into his brain, but he didn't even know it. So all he could think of was that I really lucked out. So that's almost like a similar kind of story, but in
a different direction.
Another flip side.
Crazy.
Well, yeah, and then the other one that came into my mind is you see these thought experiments where someone puts their hands on the table and then they put a mirror.
The mirror box,
or not
the
a
rubber
mirror
hand experiment.
But they put a wall and it's a fake hand and they're brushing.
That's called the rubber hand illusion. Yeah.
Yeah. Maybe you can explain it. I'm sure you can explain it way better than I could.
Well, essentially, so imagine like they say to put your hands in this box and the box is covered by a curtain. And then I think you could like see, you're supposed to be able to see your hands, but really the hand is like a rubber hand. So the hand that you see, it doesn't even have to, it turns out, be like a perfect replica. Like for me, I'm darker skinned. It could be like this totally white looking rubber hand. It like doesn't even look like my hand. And when they smash it with a hammer, the person usually recoils in pain.
Ooh.
Yeah.
That's called the rubber hand illusion. And it's the reason why tools like the mirror box exist. Mirror box is like also something I sell for rehab on, it's like if there is if you imagine like a box with a hole in it and there's a mirror on one side. So if I put my hand in this box, the mirror's on here. So if this hand is in severe pain or can't move or have a stroke or something, And my good hand is actually reflecting. What you're supposed to look at is like you see a reflection of your good hand, and then you could like do stuff like this or stuff like this, and maybe things you couldn't do if you had a stroke, or you can just purely move, and it looks like the illusion is that the left hand is moving without any pain, or that the left hand is moving perfectly without any of these kind of like motor or neurological deficits that you may have as a result of, again, whatever happened, like a stroke or something
wild.
like that.
That's crazy.
That's really wild.
So then leading back to this question about lower back pain, we talked a little bit before the show started about like how prevalent back pain is. When I worked at a physical therapy clinic for a little bit, it was the majority of the people that came in. I look at the prognosis there and it's like lower back pain, and then all the exercises were listed. I'm sure that's similar with your experience as well.
Well, it's just, the exercises are usually just, they should be like unique to the patient and not, there's certain exercises that are better and certain exercises that are bad. But just like, one of the myths I wanted to dispel is like, there's no good or bad postures, like there's no good or bad exercises, but there is certain things that may be bad for you at a time. You know what I mean? It's like how if you sprain your ankle, there may be certain things you can't do for a while, but it doesn't mean that you should never be able to like twist your ankle in again or do the things that hurt your ankle. So I think that some things like posture are like demonized because they're like, oh, this is such bad posture. And physically and like visually, you may not look great because they've done studies that show that people who sit like this like look less confident than people who sit like this or less attractive. But that doesn't mean that it's good or even predictive of low back pain, because the thing with this is that if everyone sits like this just kind of compounds upon the too much kind of syndrome. If the average person forward bends their head and neck and their low back 2,000 to 3,000 times a day, right? So we might do the same thing with our elbows, but like the elbows are my favorite example. Yeah, if you treat your elbows like we treat our spines and our necks and our low backs, if we bend them 2,000 to 3,000 times a day, we probably do. But the difference is we only go forward with our necks and our low backs, and we very rarely go backward, even though that's literally built in by God that like you can actually extend your neck and extend your back. But we walk around with our elbows and our knees and our hips and everything. All our other joints go through a full range, right? But imagine, so if you treat your elbows like your back, if you just walked around like this all day and you never fully extended your elbows, you're like, hey, what's up?
You get in a lot of fights.
Maybe. Yeah, I did martial arts.
Put them up.
Yeah. By the time you finally extend your elbows at the end of the day, you'd be like, whoa, that's really stiff, right? So that's why so many people, it's not that sitting is bad for you, but it's a lack of a change of position that's bad for you. And again, it's the same thing with running. It's not that running is bad for your knees, but running is very repetitive. So things just add up faster the more repetitive your activity is. If we just extended our necks like this or like extended our backs like this, and if you just got up and changed position like every 20 minutes, you sat on a Swiss ball or physio ball or whatever, and if everyone moved regularly and moved their necks and backs and low back or necks and low backs through a full range, there'd probably be a lot less low back pain. Because it's not necessarily that this is bad, it's just that not getting out of that position is bad. Like I can sit up like this all day and something else would just bother me because it's the lack of variability that causes things to add up rather than it being a good or bad position.
So just out of curiosity, what is the mechanism behind that? Is it like a I want to say, synovial fluid moving around, or is it like your lymphatic system that needs to be kind of pumped manually by your movement? Like what is the actual mechanism?
It's hard to say because again, synovial fluid, like joints are definitely healthier when you move around. So synovial fluid will, joints will break down faster if you actually stop moving, just like how skin breaks down if you're just like lying on a hospital bed, right? But it's not purely just synovial fluid. Because again, a lot of the findings like that you see on scans where it looks like someone has moderate to severe degeneration and potentially less synovial fluid, they're seen in completely asymptomatic people, right? Going back to even say like they took a bunch of people with like older individuals with moderate to severe osteoarthritis on an X-ray, and they only had like left-sided knee pain, but then they X-ray the right knee that doesn't hurt at all, and guess what? It looks just as bad, in some cases worse, because it's not like the one knee is older than the other,
Right.
unless they literally had just like a total knee replacement. The knees are the same age, yet why does the one knee hurt? It's not purely due to a lack of synovial fluid or arthritis or wear and tear.
Yeah.
Those things are what we call in pain science call like gray hairs on the inside or skin wrinkles on the inside. It's not like, I mean, if I didn't shave my head, I'm pretty old now. I'd have like lots of gray hair, but that's not a reason for like my head to hurt.
Right.
I have all these like dad eye bags and everything. If this was on an X-ray or CAT scan, it'd be like, wow, you have moderate to severe skin degeneration, but it's not enough for my skin to hurt, right? That's why like using more gentle terms instead of these thought viruses like gray hairs on the inside, what I would tell people who are just like so worried about me looking at their scans, like, hey, you know what? If that doesn't show a fracture or cancer, I don't care because we can't change what that says, but we can change things that you're essentially doing potentially one thing or many things that kind of fill up your cup or sensitize the system. And I just have to find out what desensitizes your system. So if you do like, that's in everything I do is called like a recovery plan. So we avoid the things that kind of trigger your complaints and makes your system more sensitive, regardless of what's your back or your neck or your shoulder. Then we do a high dosage of particular movements that desensitize your thing or your system or empty your cup.
Yeah.
And maybe other things too, like get better sleep, maybe put turmeric in a smoothie for anti-inflammatory stuff. Like I do way more than just like your kind of like standard PT because I try to look at like the whole ecosystem rather than, do these 10 stretches in this back book.
Right.
Could you walk us through that then a little bit? Like if I were a patient that was coming in with the low back pain and you just said, let's figure out what's sensitizing the system and what we need to do to desensitize the system. I mean, obviously, as you've expressed, like it can be very unique and it's not necessarily this is a one size fits all treatment, but could we just maybe walk us through some examples? If I'm coming in with low back pain, what is it that you're doing to determine what we need to stop doing and what we need to start doing?
Yeah. A lot of times it comes back to really detailed history. Like I might spend 20, 30 minutes on a history. Has this ever happened in the past? How has it been in the past month or so? Is it getting better, worse, or not changing? Because a lot of times it's getting worse. And you have like neurological signs or something, I may need to refer you out. But if it's getting better, or even if it's like come and go, if it's like I always say, I would rather see a 10 out of 10 intermittent pain because 10 out of 10 intermittent pain to me is easier to treat than a 2 out of 10 true, constant, like unrelenting pain that never ever changes despite any treatment or anything. Because that may be a nervous system that is actually unresettable. But 10 out of 10 intermittent pain means there are times when your nervous system is safe. So to me, that's like you fit into what I would call a rapid responder category. There's probably something today that I'll be able to find, a movement, a position, or stretch that you can dose over and over and over again to eventually convince your nervous system that it's safe. So I go also like ask you simple questions like, well, what makes it better and what makes it worse? And we kind of run from there. If you say like sitting and driving and bending and squatting and deadlifting make it worse, we may need to avoid or modify those things temporarily, again, but not forever. Because I think a lot of things with the back is like, oh, you should just never deadlift again, or you should just stop heavy squats, which was like the worst advice ever because everyone should literally be working out more instead of working out less, right? Yeah. And again, they've done research that shows that people who do deadlifts have less pain than people who don't do deadlifts. Sure. So it's really hard to say that deadlifts are bad for your back.
I feel like I've only heard one other physical therapist say that deadlifts are good for your back. So
you're not listening to the right
I'm not
PTs.
listening to the right PTs, but like I'm just
those PTs also probably don't deadlift.
Yeah.
But I mean, anyone who says that is one, not up with the research, and two, just plain ignorant. I mean, that's just like saying, again, I've heard PTs say running is bad for your knees, but it's like it's not. That's like saying lunging and jumping is bad for. Is jumping bad for your knees? No.
Yeah.
In fact, they've done studies that show that not running is worse for your knees because people who don't run at all tend to have more arthritis than people who do run.
Right. That's crazy. Anyways, I just thought that was very interesting. But I appreciate that the field is moving more towards these types of modalities because it's like, I guess the reason why I bring that up is the physical therapist that I hear is like these are dangerous compound movements. It's very you're working with very high loads and it could result in very severe injuries. When really it's like. It's working. It could, yeah. In a worst case scenario, and if your form isn't good, all these things can like build up. But like, really, I am total agreement with you. Of like, if you want to strengthen your back, you've got to do it by strengthening your back. You can't like work around that. You've got
Do
to
bicep
provide
curls forever and get a stronger back.
exactly.
Right. And the other thing is like, thanks to Paul Hodges, he's like one of the physical therapists who first did like all the research on low back pain and how that affected like core. Everyone like he kicked off the whole kind of like core stabilization movements, and everyone's like, oh, you got to work on your core for low back pain, and also just to make you a better human being. Like literally became the answer to every problem known to man. And then pain science came along and turns out that like that doesn't relate to low back pain at all. I mean, is it good? And people are like, what about core exercises? And I'm like, hey, look, I've treated like Olympic lifters with the strongest cores in the world, and they still have pain. And I've treated little old ladies with like who couldn't plank for, negative 5 seconds, and they have no pain whatsoever. It's really hard to say that like that's. I'm not saying it's not good for you. That like it's good for maybe performance and sport, but does it prevent low back pain? No, it doesn't prevent low back pain because the strongest athletes in the world with amazing cores can still get low back pain.
It's so interesting because forgive me if I'm going to try to dumb this down a little bit because I'm trying to keep up with what you're saying. But like when I heard you saying like figuring out exercises to, I don't know if you said the word trick, but this is how I remember it, tricking the nervous system into relaxing. So the suggestion that the nervous system is doing something and creating pain where it's like there may not necessarily be this huge injury or issue that needs like really intense care. It's like you're trying to reset the nervous system so that you can get rid of the pain.
Yeah, I say reset.
Reset.
Yeah.
Okay.
Essentially, like, and going back to how do things work, whether it's like a manipulation or adjustment or scraping or acupuncture or needling, all those things are really just inputs. Like they are like, going up the nerves, and your nervous system has to make a judgment. Is this safe or is this dangerous? And often the more novel or different and not the more novel and non-threatening the input is, it can reset that area. And now all of a sudden pain and movement thresholds, like before there's kind of like what I call a CNS or a central nervous system lockdown or a neurological lockdown where the muscles are all tight and it's trying to guard the spine or it's trying to guard the hip or something that may or may not have been injured. But anytime a treatment works rapidly, it's not because something was put back into place. It's because the perception of threat is now reset, like an alarm has temporarily gone off. So now movement and pain thresholds are improved. But previously, it would have been like, oh, we just fixed you because we were put back into place. But since all that research has come out that you're not doing anything mechanical to put something back into place, you're not like realigning something, that we know that it has to be some sort of change in perception at the central level that changes movement. Because you're not rupturing anything.
Right. This is just kind of clicking.
So that's part of my brand.
Oh, go ahead.
Yeah, it's part of my brand of modern manual therapy is that every treatment works the same. Because I've studied a lot of different kinds of treatments, and it's easy to say like, oh, soft tissue work is the best, or adjustment is the best, or dry needling or acupuncture is the best, but they all work on the same mechanism of just changing perception. Certain things may work better on others because maybe you can sell it better as a clinician, or maybe your therapist has like better hands, or they have more training, or
there's better codes
for whatever
to
reason.
charge
I don't know. People also have like people have preferences too, right? I say that like treatments are kind of like preferences. Like you might like chicken steak and sushi, but if the therapist doesn't have chicken steak or sushi on the menu and they only have like these particular treatments, maybe you won't respond as well.
Yeah.
So it's not just because there's a big movement in physical therapy toward let's promote active things instead of passive being traditional manual therapy where I'm going to fix you, or needling, or, where you just go and go and go. Let's try to give the patient an empowering way to fix themselves. That's why I call them recovery plans. Like I try to see the people as little as possible. Maybe on average, I see people like 2 to 4 times versus 25 years ago, I was seeing people 2 to 3 times a week for like 30 to 60 visits, or until they break up with you. That's what I say, like, oh, you need to break up with your physical, like every physical therapist, chiropractor, massage therapist, whatever, give them 6 tries. If you haven't gotten any relief in 6 tries, it's very unlikely, and their stats to back this up, it's very unlikely they're going to do anything for you. And they could be trying their hardest.
Wow.
They could be trying their hardest, but if you don't respond, it's not like they're saving their magical home run super technique for the 7th visit.
Right.
Right.
Right. This is just making me think it's like kind of clicking some things into place for me. Just this past summer, like in August or something, I kind of had like a pinch on my shoulder on my left scapula that had been bugging me for a couple days, and I was like stretching and trying to figure it out. And I woke up one morning and felt real stiff again, like my neck was heavy, and did this stretch and arched my back, and I felt like a pop on my scapula, and like in the most pain I've ever been in, ended up like literally passing out on the floor from hyperventilating from pain and going to
Oh,
the
wow.
ER. It was crazy. I've never had an experience like it. And I was like, okay, well, chiropractic, physical therapy, I'm going to do one or both. And I went to chiropractor first,
Right,
just to
because it's
see.
the easier way.
It's the easier way. I had just met this chiropractor at some networking event the week before, and I was like, it's quick and easy to get in. Let's just try this first, something. And it was interesting because he did this very long examination and did all of these kind of different testings for movement and holding and strength. And it was the longest time a chiropractor had ever spent with me doing those kind of tests. And he eventually was
Sounds like a PT.
I am almost, yeah, it's kind of what I was thinking. He's like, eventually was like, I'm almost positive, before he'd ever done any kind of adjustment or anything, he's like, that you have some kind of nerve that's actually up at the base of your neck, and it's caused this issue. And it's been, you said something earlier, which is pretty much what he said, which I'm going to biff, but essentially it was in protection mode, thinking that there was all these issues, and it was causing things to tighten up in order to protect. And that's why I ended up kind of having an injury actually separate from where the nerve bundles were. And that wasn't even actually the issue at all. And he just did the little manual, like the gun adjustment, and it was literally 4 visits maybe, and I was experiencing no more pain at all, and found some other issues simultaneously fixed. And I was just kind of like, well, that's some cool magic. But now that I'm listening to you explain this, it's like light bulb and coming together for me that there were these other issues that I was experiencing that were actually related to my nervous system.
Right.
And so could you kind of like unpack that in just a little bit more detail about what is happening?
Yeah, real
in
quick.
that
I mean,
instance?
like they've done studies where they look at pain pressure thresholds. Like they'll see how hard can they push using like some sort of dynamometer or measuring device. Like how hard can they push on someone before they feel pain? So that's measuring their pain pressure threshold. And then if they have low back pain, maybe they have like less pain pressure threshold at their back, and maybe if they have radiating sciatica, or they also have a certain threshold in their leg that's also better in the leg that doesn't hurt. Then they do something like a spinal manipulation, like an adjustment or something. Then they'll look at the pain pressure thresholds, and not only does it improve in the spine, but it also improves in like the shoulder. Because again, David Butler, who's one of the therapists that founded pain science, he calls it the drug cabinet in the brain. It's very similar to like if you get a cortisone injection in your shoulder because your shoulder hurts, but you also happen to have hip pain, and you can tell the doctor about the hip pain feels better because it's a systemic effect. So
Wow.
when the brain is under threat, certainly it's kind of like being protective and vigilant about areas that it feels that it needs to be protected, but anything else, because there is literally an entire systemic effect of improving pain pressure thresholds everywhere where you might have pressure. It's again, that tells us that it's more central and not like a pure mechanical thing that happened with any treatment.
Wow. Yeah, that's wild to me, just to kind of think about how it's all connected. And I do remember him talking to, like, asking about like any other ankle injuries or any other place that I have pain that's kind of like persistent or comes back. And like me telling him all of these things is how he got to that point. He's like, yep, before I've even touched you, I'm pretty sure this is what's going on, because of he could just like connect all of the dots. And it just kind of blew my mind. I hadn't really thought about it in the terms until you started describing that. It sounds like there's like a lot of different directions we could go with this, and we've barely skimmed the surface. We haven't even talked about mobility much, and we've touched on back pain. I feel like there's so much more you have to say. You bring a lot of passion and knowledge. So I'll just say we'd love to have you back so that we can do a part 2 to this episode. And just thank you so much for taking the time to sit with us. Is there anything that you want to leave our listeners with before we sign off here?
Yeah, sure. If you ever get bad news and you tell someone about a scan, or someone tells you shouldn't do a particular exercise or activity that you love, why don't you email me or reach out on social media? I'm at Modern Manual Therapy on Facebook, Instagram, and YouTube, and I always get back to people who ask me questions. I don't do, I do online virtual consults as well, and many times I can get you better informed or see me no more. So,
I love it.
Yeah.
I love
That's
it.
awesome.
Well, thank you so much for taking the time to chat with us today,
Thank
Dr.
you so much
A.
for
We look
joining
forward to
us.
having you on again.
All right. Thanks. You guys have a great holiday.
All right, you take
Bye-bye.
care.